Good morning, everybody. Welcome, everybody, to this session from Cornea Society of India. And Dr. Namrata Sharma is here as the co-chairperson. I'm Dr. Pranita. I'm the moderator for the session. So I hope we are going to have some great talks, and it's going to benefit you, not just as a cornea specialist, but as a general ophthalmologist. What all you can do in the cornea front is what is the agenda or the motto of this session, that we have common topics that you deal every day in your daily practice. Okay. So the first presenter is Dr. Namrata Sharma, and obviously she needs no introduction. We all know her very well, and she'll be presenting on a management of a case of acute eye drops.
HDMI लगेगा direct लग जाए. Thank you, Pranita. And Somshila, can you also come join us here on the stage, please? I would be talking to you about management of acute eye drops, and this is the talk which I had actually given in World Congress Cornea in US, which was held last year, yes, in American Academy of Ophthalmology. So there are no financial or proprietary interests, and we all know that acute corneal eye drops is a tear which is there in the Descemet's membrane, followed by leakage of aqueous into stroma and epithelium, and there is marked corneal edema. The incidence after keratoconus is highest, but it can also occur after pellucid marginal degeneration, keratoglobus, Tyrrell's marginal degeneration, and even after surgery such as LASIK, RK, DALK, and penetrating keratoplasty. Now, this was our study, the childhood keratoconus study of 116 eyes, and in this the incidence was 7.7%. This study was done at RP Center. The risk factors are eye rubbing, young age. It is more in males with steeper keratometry, vernal keratoconjunctivitis, atopy and Down syndrome, mental retardation, and trauma. And patients will generally complain of marked decrease in vision, photophobia, pain, and corneal haziness. Then there can be congestion, marked stromal epithelial and microcystic edema, intrastromal cysts, and Descemet's membrane tear with or without detachment. So these are just some of the cases to show acute corneal eye drops in case of keratoconus, pellucid marginal degeneration, keratoglobus, and post-RK keratectasia. So whenever there is ectasia, there can be this complication. And this is something that we published, acute eye drops in keratectasia after radial keratotomy. Then it can also occur after post-microbial, post-CXL keratitis. And this was again one odd case that we published. Now the investigations most important, I think, and easily available is anterior segment OCT. And you can actually see, you can also do ultra biomicroscopy, but it may not be available at all places. But that gives you the best resolution, and it helps also to plan the surgery and monitor the follow-up. Now we've also described what is called as the eye drops resolving index using a UBM, which is the ratio of maximum thickness of corneal edema at presentation vis-a-vis corneal thickness at a site 2 millimeters away, and it should be 0.8 to 1, and then you know that it is actually resolving. Now, anterior segment OCT, it looks something like this. It identifies the Descemet's membrane detachment, depth of epithelial and stromal edema, intrastromal cysts and cleft, and helps you to plan the surgery and monitor the treatment. There are 3 patterns of Descemet membrane detachment: break with rolled ends, break and flat ends, and detachment with no break at all. And in the natural course, secondary corneal scarring would occur and healing will be there, but it will take about 4 months to happen. Now there are various treatment modalities which have been described. As soon as this case is diagnosed, you give medical management in the form of topical hyperosmotic agents, steroids, lubricants, antibiotics, cycloplegics, and topical anti-glaucoma drugs. As far as the surgery is concerned, people have used intracameral injection of air and gas, compressive sutures with intracameral gas injections, stab incisions can be given, even people have done endothelial keratoplasty. And some people also advocate that you can do an early DALK for these cases. Now, what is the role of intracameral gas or air? It is that it helps to reattach the Descemet's membrane to the stroma. There's faster resolution of corneal edema. It reduces the risk of corneal neovascularization and improves the chances of graft survival. You can inject air, SF6 or C3F8. Of course, repeat injections are required if you use intrastromal air. Then there may be rise of intraocular pressure with the intracameral C3F8. and endothelial toxicity may be an issue with SF6 or C3F8, but at that point in time, you're not bothered so much about the endothelial toxicity, more bothered about the fact that it should close. So when you give intracameral C3F8, this is how it closes. And again here, this is yet another case. You can see how coalescence of these cysts have occurred after intracameral C3F8. And this is our case that we had, again C3F8 was used, but this was a case of pellucid marginal degeneration. The hydrops were somewhere here, and see how over a period of 2 weeks this has caused resolution. Now, there can be non-resolution also, especially when you inject air or gas, because sometimes there may be fish egging. The cleft is so huge that these small droplets of the gas or the air, they have fish egging and they go intrastromally. Now, another method by which you can deal with it is the use of compressive sutures. So here, 4 full thickness compressive sutures are being used to cause apposition of the ruptured Descemet's membrane. And again, here also the signs of resolution begin at first week and complete resolution occurs by 3rd week. Now then there are combined techniques of compression sutures with gas, and again the results, although there are not too many studies with too many cases, but they have been found to be good. Now what we described is AIOCMTC intracameral C3F8 guided C3F8 injection with stab incisions. So this is just to show how you look at the anterior segment OCT and you just see where the areas of the clefts etc. are, and then this is how it is done. So you give a stab incision, and after giving the stab incision, the C3F8 is injected, and then just look at these dark areas. Where you see these dark areas, you give a stab incision. So actually the fluid is going to come out from those areas because they are nothing but the cystic spaces of the clefts from which the fluid is coming out. And this was also published. And this is just to show how resolution in the same case that I showed you is occurring over a period of time, and there is clearing of the cornea as well as the resolution of the acute hydrops. These are some, again, 3 cases. Notice this is such a huge keratoglobus with the hydrops, and that has also resolved. And these are the intrastromal cysts which have coalesced. Now again, with the help of the intraop OCT microscope, it becomes a lot easier because you can actually see where you have to give stab incisions directly under the microscope, and you can give there, followed by the injection of the gas. And people have even done endothelial keratoplasty in anecdotal cases with good improvement in visual acuity. Now, why do you need to cause an early resolution of this? Because there may be corneal neovascularization, perforation, pseudocyst, fistula, scarring, etc. And when you have vessels, then there's increased risk of graft rejection. So you are actually preventing that. And this was one of our cases that we reported, acute hydrops with secondary bacterial keratitis. Again, scarring and neovascularization in this. This was a case where there was a corneal perforation in case of acute hydrops, which was glued. I think Pranita would remember this case. This was during her time in RP center when this was glued, and rather than putting a graft here, this thing, glue was used. Now, this is a review article on management of acute hydrops in ectatic corneal disorders. So to conclude, acute hydrops can be visually debilitating if not managed timely and appropriately. Air or gas injection is useful in these cases. Intrastromal drainage of clefts and cysts should be done. Microscope integrated and intraop OCT is a useful tool to delineate its morphology. Apposition may be caused by use of sutures or DM grafts, and early treatment is required to circumvent the complications. Thank you very much for your kind attention.
Thank you, ma'am. That was a really wonderful presentation. Anybody from the audience wants to ask any question, as there's a golden opportunity, you can ask, ma'am.
Yesterday also going on the cornea test groups also. During the acute hydrops, the suture, hexagonal suture, or only C3F8, which one you prefer?
So I think Somshila can answer that. Somshila, because in your institute they are doing compression sutures, we are not doing compression sutures.
Actually, for years together, we were doing exactly as Dr. Namrata showed, and I was a strong proponent of doing it early. There were some people who would just wait because even it naturally would resolve. But then, as Dr. Namrata pointed out, there are many complications of just waiting for natural resolution. So obviously we would do gas tamponade or just air tamponade. Sometimes you have to repeat it. And then recently my colleague Dr. Sunita Chaurasia, so she relooked at compression sutures. It's not a new technique that had been described before. And the difference was that, so based on the anatomy, the configuration of the DM break is to apply the sutures in a radial fashion. So not in hexagonal. Some may be hexagonal fashion and some are radial. And I was amazed because the quick time to resolution. In fact, intraoperatively, as you start the case and finish the case, you can see that the fluid is almost out.
Decomposition.
And within a week, you have literally resolution of fluid completely. So I think this is a great technique to combine the two. And now we're not focused on the intraoperative, the gas tamponade. We're more focused on the compression sutures and how to apply them. And if you get the right way of applying it, then you will definitely be able to resolve most of the fluid and a very rapid resolution, 1 week to 2 weeks. So she's looking at that, published initial few results, and we're looking at it in a sort of a more comprehensive way for time to resolution and an algorithm on how to do it. Yes.
Okay, that's great, ma'am. Thank you.
Yeah.
Thank you, ma'am.
That
So
was
we'll
absolutely a wonderful talk and literally covering everything on it. I was thinking that she would in just 7-8 minutes.
yes, and
That's
out
marvelous.
of one topic of eye drops, we have seen at least 10 publications out of that from ma'am.
Yeah, I think the youngsters here, and we did the same mistake, we just do things and not publish it, should learn from Dr. Namrata Sharma and the group at RP Center that any case is valuable in publishing. So I think that when I look at the cases you have, I think even humne bhi aise kiya, but you have credit to it because you published them.
It is very important because all of us are so intelligent. We all think alike, we all do alike, but it is more about who receives the idea, makes it happen and publishes it. Otherwise, you will keep regretting, I always used to do this thing. But Somshila, you are
No.
also good at publishing.
So,
But then I think that is something.
and you can never say you're busy. Who can be more busy than her?
So with that, we'll move on to the next presentation by Dr. Somshila Murthy, and she'll be presenting on the topic 10 pearls in the management of microbial keratitis.
So I'm from the city of Hyderabad, so obviously I bring you pearls, and you can collect your pearls on the way out. They may just turn to be iris pearls or something. So in the next 7 minutes, I'll try to just give you a brief 10 tips actually, not even pearls, they're not even pearls, 10 tips because probably you already know them, so they're not so precious. So what everyone should know. So the first tip, not to appear very preachy and give you Miss Universe answers, is that there are 10.6 million corneal blind in India. So that's the tip, that's the reason why we should work towards getting these patients out of corneal blindness due to microbial keratitis. I was discussing with some of the colleagues here who are practicing in Patna and these areas, and they said that a lot of patients who are referred to them from the rural areas, a majority, maybe 70-80% are using corticosteroids. So they've been prescribed that by the local ophthalmologist or whoever's seen them. It may not even be in ophthalmology. It's because of the lack of care or awareness. So that's corticosteroid usage is high. They may have started using it and then got the corneal infection. And continued it during the corneal infection. That's one. So the conversion to evisceration is very high, which is a pity. And the second problem that they have here is that the cocktail treatment. So every patient has everything going on from antifungal, antibiotic, and antiviral also for good measure. So no medication gets a chance to work. So I'll take you through this. This is the first tip. So we need to work on getting the patients out and not get them into blindness. So the other very important second tip is that the history that we don't pay much attention to, we should also look for history of weird things like contact lens wear. The patient might have recent cataract surgery. So here it's not just the cataract, not just the corneal infection, but even the wound might be infected. So watch out for that. You may have history of RK as was shown in the previous presentation, and these ulcers are going to behave differently. So a lot of us are now seeing the RK patients coming back in their 40s and 50s who are coming back with these problems. Not a lot of them, but some of them. And these are because of the epithelium never being very healthy in these patients. So also look for history. Of course, if you have a patient who has a corneal transplant and patient reports to us saying that there's some problem in the eye, it's more likely to be infection related to a loose suture. So always remove loose sutures if you're practicing cornea. So to divide the infections, we have commonly encountered infections like bacterial, fungal, and viral. Then we have uncommonly encountered infections, and then we have the non-infectious causes, but they look just like keratitis. So for bacterial keratitis, the focus is always on should it be empirical therapy versus protocol-driven therapy. So the third tip here for this class, because I was in the teacher's session, is that yes, you can use empirical therapy, commercially available broad spectrum, but bactericidal drugs versus a combination, but that is only if you have a non-site threatening and you're very, very sure that's a bacterial ulcer based on the history and so on. So use these for small, less severe non-visual threatening ulcers which are peripherally located. And if there's no response within the first 24 to 48 hours, because these are bactericidal, you should get a response very rapidly, then don't wait. You must investigate or refer the patient to higher center, recheck what you're going to do for this case. So if it's something as severe as this, just that you can't, you take it easy, you have to use fortified antibiotics and watch carefully because this patient might just develop a perforation or might rapidly progress if you're dealing with, say, Pseudomonas, which is resistant to most of the drugs. So these kind of patients, you cannot do empirical therapy for these cases. Now, commonly encountered fungal keratitis, 40 to 50%, maybe even higher based on where you're practicing. The patients just come to us in a week or 2 weeks with this kind of picture. This is hardly a 2-week presentation for the patient. Again, you can't wait. Here we offer therapeutic PK to these patients. Don't beat around the bush. And this second case, maybe you might wait, but the problem is that you have the infection going all the way to the limbus. So in this second patient, we also added intrastomal injections and we could achieve control of the infection. So the tips for managing fungal keratitis is that still I would say that down south at least, natamycin works and it's a drug of choice for all cases. And voriconazole, especially for aspergillus and also for patients where if you've identified yeast, voriconazole is an excellent choice. And also don't forget to use systemic therapy for patients where the ulcers are deep, where the invasion is more towards the posterior stroma or the limbus, as in the cases that I showed you. So what about this? Is this fungus? No, it's not. This is a patient who had, again, leaf injury, but not every vegetative matter injury is fungus. And this looked like fungus, so this is what we have described it as Pythium keratitis. So the tip here is that the treatment, if the patient very rapidly worsens but looked like fungus, then think of could it be Pythium, and there are certain classical differentiating features which have been described in the papers. And the drug for this is linezolid, which is an antibiotic actually, and then oral or topical azithromycin for these patients. And earlier we were just losing the eyes. They would come, we would assume it's fungus, we scrape it, it looks very similar to fungus. Even the microbiologists were fooled. They would report as fungus. It is a kind of a fungus, it's an aseptate fungus. And so we would keep on using antifungals, it would just rapidly spread. We would do therapeutic PK and have recurrence in these patients. So luckily we finally figured out what is the mantra, and it is linezolid. So we're very, very fortunate to have this from our group. And this is a large table showing many, many causes of indolent keratitis. Patient is not improving. What could be the causes? It ranges from bacteria, which are very low in terms of virulence. There are fungi, there can be, maybe it's a virus, maybe it's a parasite, and then there are also non-infectious causes, which are interesting things like it could be a foreign body granuloma, there could be bee sting injury and drug toxicity. Sometimes VKC shield ulcers are misdiagnosed as chronic infection. So look out for cases where the history is there for months together. So it cannot be the routine fungal or the routine bacterial that you're dealing with. So the rare infections include acanthamoeba. It can be there for months together. This is what the cysts would look like. Microbiologists would say, oh, so pretty, but we don't like them. And then there's microsporidial, which can be the keratoconjunctivitis version, which is a very innocuous version. We don't have to worry much. But when we have stromal microsporidia, the problem with this bug is that there's nothing medical for it. So most of the time we have to do a therapeutic keratoplasty. But the good news is that the results of therapeutic keratoplasty are extremely good. So you can use steroids and you can have a good outcome, provided you use a good tissue for these patients. And then these are some of the examples. Don't forget HSV keratitis. It often mimics either a PUK or it can even mimic a case of bacterial keratitis or fungal keratitis. So these are some of the examples of atypical organisms that can look like typical infections, but they need different treatment. Nocardia and atypical mycobacteria need amikacin, and HSV needs acyclovir or valacyclovir. So the second last tip is about drug toxicity. So there's a patient who had a graft infiltrate, perhaps he had an infiltrate, and then everything possible was started. In fact, we call this as A to Z therapy where everything, in fact, there's a drop called alphabet. So maybe, I didn't know there's a drop called alphabet and this was given to this patient. I think it's an anti-glaucoma medication. So the patient was literally on A to Z medications and this had just drug toxicity. Withdraw everything, stop all treatment, just use lubricants and the patient gets better. And the last and final tip is about peripheral ulcerative keratitis. Sometimes you may confuse these cases as infectious keratitis, so they're not. So these are the various manifestations. You can have this particular manifestation, or you can have like almost 360 approach here, or this is a patient with scleritis who also has the superior portion looking a little bit like infiltrate. So it is an infiltrate, but it's an inflammatory infiltrate, it's not infectious. So these are cases of PUK. So thank you very much, and I hope this gave you some tips.
Thank you, ma'am. That was a wonderful presentation with a complete outline for the management. Ma'am, I would like to ask you one question. Ma'am, any opinion on combination antifungal therapy to start with in patients, like combination of natamycin and voriconazole, or what is the time period that we wait before shifting or adding on voriconazole?
So we do, so if there, we do, I don't know the correct answer to your question. It depends on the practice management at our center. What we tend to do is start them off on natamycin and oral medication. We have a low threshold for therapeutic PK, as I showed you, because it's a tertiary care center. So many patients come in. So for some reason, if the clinical experience is that this patient has a chance and may likely to improve, so we might add on a second drug as well. So we do combination therapy with natamycin and voriconazole, though initially it was thought it's not logical to use two medications, but we do that now anyway. And of course, in desperate situation, we obviously do that. The patient is waiting for the transplant and not getting fitness for some reason, then we already have the patient on both drugs as well as oral for that matter. So it's just like throwing everything, all your weapons, throwing them all in,
Yes.
basically.
So we actually, there was a paper that we published on the TST protocol
Right.
wherein we added on voriconazole. In that also we waited for 7 to 10 days before adding on voriconazole
Right.
after adding topical natamycin. So almost there were additional 20-25% patients
That
who
you could
responded
salvage, yeah.
after adding
Yeah.
topical voriconazole.
Yeah, so based on that paper, we probably, I think most of us now don't wait that long also.
Yeah.
Again, it depends on the entry level.
Yes.
So if you have a patient just coming in, don't throw both the medications, because most of the patients, if it's a small fungal ulcer, are likely to respond
Only
to natamycin or voriconazole, depending on where you're practicing.
Thank you. Any other questions for ma'am?
Some of the patients are very refractory endoexudate surgery. In this case,
That's right.
yeah, some of them, because you are giving the epithelial stromal on healed up, but there is a very refractory endoexudate surgery. In those cases, how you approach, ma'am?
That's tough
So
case.
tips and tricks
We can try intrastromal. Intracameral, I feel that it just increases the toxicity and it doesn't work to cure, to affect a cure. So intracameral alone, you can't expect that. So you can still try intrastromal, but this kind of patient with such deep-seated, I think that the fungus has almost crossed the DM, and that's why you have that endoexudate sitting there.
Exactly.
So that's an indication for surgical management, unfortunately. But otherwise, intrastromal you can try.
Either go ahead directly with the TPK.
Sorry?
Better to directly go ahead with the TPK, ma'am.
Yeah, better if you have everything with you to go ahead and do a,
TPK.
yeah.
Or we can try for the interstromal one surrounding the.
That's right, yeah, that's right.
If you don't have the
If you
access
don't
for the-
have the access
for
to
the
tissue, yeah,
those who are in the.
exactly.
solid
Or you don't have
epidermis.
anybody who can be real
Yeah.
expert at doing that. So,
That's good. Thank you, ma'am.
thank you. No, so you have to be very clear about the indications for intrastromal, because with intrastromal you have to give 2 or 3 injections. You have to wait in between each injection. It does have some, not toxicity, but inflammation that comes because of the intrastromal, the intervention that you're doing. So, so it should be that you know which lesions are likely to respond based on their papers from RP center. So either it's isolated, maybe it's peripheral, so you can expect the limbal vessels to come in and help you heal the lesion. Or even if it's in the central area, but they're deeper stromal, but it's a limited area. So otherwise, it should not be an attempt to try before you go for therapeutic PK. I don't think that approach will help, because you're going to waste a week or couple of weeks. So I think that, I'm not sure, but personally, what I practice is that very large lesions, for us, we can't wait. I think we should just go ahead, and these are lesions that Because most people elsewhere have already started the patient on antifungals when they come to us.
Exactly. When to tertiary center, they are referred almost before
Yeah.
that they are treated by the either cocktail therapy
Yeah.
or natamate is there.
But on the other hand, if you, the same point, if you don't have access to tissue, you're not able to operate on the patient, and then this is another method which you can definitely give a try.
Sometimes there are cases where the infiltrate per se is not as bad,
Yeah.
the endoexudate or even hypopion sometimes going to an extent of causing a people to withdraw, but infiltrate is not that bad.
Yeah.
So what's your idea on, doing an AC wash or removing the endoexudates, or does the intrastromal work here better than the APK?
So AC wash, typically, it doesn't help. It can just help you momentarily because it's very frightful to see that hypopion. It really is. So you can wash, but you have more fibrin, more AC exudates coming in. That's a separate discussion. I'm just hijacking the discussion here, but
No,
instead of that, I
there is
think,
there is a randomized controlled
Yeah.
trial that has been done where the AC wash with intracameral antifungals has been compared to topical therapy and with intrastromal. So there was no advantage of an AC wash and intracameral injection. In fact, they had more severe inflammation and it did not have any advantage. So that was the conclusion of that RCT that was done on AC wash. Okay.
And one add-on, I just one thing I noticed, ma'am, if you do the AC was then invariably the more reaction, the pass formation is there.
Yes, so
Pass
that,
and formation is
yeah,
there.
that's right. So I would discourage against AC wash. It's very
Yeah, we
difficult to
directly
stand
go
by.
ahead, go ahead with the TPK.
That's right, yeah.
Let's get
Or
better to salvage
intrastromal.
the
Yeah.
Yeah, thank you, ma'am.
Thank you.
okay, with that wonderful discussion going on, we'll go on to the next presentation by Dr. John Sarkar on dousing the fire approach to complex chemical burns.
Sound check.
So how many of you are residents here? Oh,
That's great, ma'am.
oh, wonderful. So this is a residence teaching session, huh? So you guys should be asking questions. Okay, now when I said the bad word now.
No, this is the best opportunity to you hear the Somshila ma'am is there. She's a wonderful teacher.
So what you should do is that first read up about the publications from RP Center. They're very descriptive. They give you the indications also what kind of cases. And you just match it. You have so many fungal ulcers. Some of them will match with what you see there. And those are the patients to go in with intrastromal voriconazole. Read up about how to do it. Very simple. For any cornea surgeon, any cataract surgeon, I think it's easy enough to do that.
Yeah, thank you very much. So, very good morning to all of you. So, learning is the constant evolutionary process. That's why we're here from Neanderthal to Homo sapiens. And sharing the knowledge is the best way of learning. So, I'll be presenting dousing the fire approach to complex chemical burn. I have no financial interest. So, these are some of the eyes which refer to a cornea clinic with severe degree of the moderate to severe degree of the anti-segment manifestation. All the patients having the already treated by somewhere else. So it's a time to understanding is that these eye are not amenable by the medical management. You have to, this is the time to right time to send your patient to the respective cornea specialist who are dealing with these things. So these are the cases are not amenable by the normal medical management. We have to salvage the eyes. So the plan of presentation, that special case scenario in subacute or late presentation, clinical evaluation, rational surgical plan, and of each cases, surgical tips and tricks, discussion, and tech clinic messages. So I'll be highlight this presentation highlights the appropriate management and the outcome by the surface reconstruction and the recent advances. Prerequisites for the compromised cornea eyes: no surface inflammation, moist eye, the correct claim instability, IOP should be controlled, sound posterior segment, appropriate alveolar bar calculation when planned for the cataract surgery or a K-Pro, rational surgical plan with minimum tissue handling, and the team approach is always rewarding. And the quick hands, the investigations are, if your cornea and clear, just check the RFID is there or not. Anto-segment OCT to know the depth of the scar and thickness of the corneal surface or panas. UBM to know the anto-segment and the ciliary body status. Uneven breast scans must to know the sound posterior segment. So I'm sharing my first cases. This girl came to us for the cosmetic correction. She has a difficulty in getting the marriage. But the one clinical examination I found it that we have only 360 panas is there, but she has a sound posterior segment. So simply averting this her wish for cosmetic contact lens, what we are planning, just I'm showing here the surgery. Lower the sound please. Planning for her excision of the panas, and it's very easy. Once you get these things, just like a rexis, just like onion shell, you can peel it off. And this bleeding will goes up until unless scleral perforating vessels are there, don't cauterize the surface. Please. We have all of the presents, so there are no extra instrument, all of us cataract surgeon overall. Placing the AMT over the excised surface, secured fibrin glue. Taking the slide beads from the other eye prior to the surgery, we have taken the consent. There is no anteroposterior surface of the sled beads, so you can place it over there. With centripetally placing in 2 rows, sparing the visual axis. Sorry for this. And secured is fibrin glue. Just wait for our basil has been placed. A temporary suture trachytherapy has been done. I'm just move on the post-op. This is the 6 weeks post-op. You can see the relatively how the cornea is clear. And this is the for the post for 6 months, and I think it has been my fast slate. I have done 2016 end or 17, and she has been follow up for last and get married, and now she didn't come but follow up for last 2 years. So that is a good thing, I think. Now I move on to the second cases. I'm not going to in details of the cases. These boys come to us. The 11-year boy who had a history of the on and off redness, and in some of the hospital, government hospital, they put the steroid antibody combination drops on and off, and the lots of lubricating drops. So what we find that he had a history of chemical injury, tuna injury, couple of years back, and almost there is a near total LSD is there. Only the sparing part is there, 2 o'clock to 4 o'clock position, and there is a symblepharon is there. So we are planning for this boy. We are planning for the symblepharon release with the surface reconstruction with the autoslate from the other eye. So just sharing the videos. We are releasing the symblepharon. We are not cutting the conjunctival, going to subconjunctival level. Those things don't need any very sophisticated instrument. Just need your training and expertise. So you can do it your own setup after proper training. It has been done in general session as this 11-year-old boy. Excision of the panas. AMT has been placed over the whole ocular surface till the fornices. Secured with fibrin glue. the furnaces we are doing. Taking the lead bits from the other eye. And just like previous cases, we put it over there and BCL has been placed and tarsography has been done. I'm just moving to the post-op. This is the immediate post-op as tarsography is there. We can see the BCL and the small slide bits are there. After releasing the tarsography, you can see the relatively clear cornea, no symboliferon, and the patient having the 6/36 vision. We have the patching therapy, and meanwhile he lost the follow-up in the COVID time. Though he came the last 2 months back, the cornea is pretty clear, and now the vision is 6/18 or by stage 6/12 partial. So that's the good story for these things. This is another patient. I'm just sharing these things. What I did the mistake because this patient is a young German. They come to the during the come of the COVID. So we have done the accidental injury by the bilateral chemical acid injury while opening the bathroom cleaning acid. So we have done the advancement with the multiple surface reconstruction procedure, but it is very disappointing. Ultimately, every time it was surfaces like this, other I have this type of vascularization. Then I was really disappointed. I sent the patient my teacher, Dr. Geeta in Chennai, Shankar Netrala. Then what the madam was doing, she has what I did the mistake that every time put the oral steroid, topical steroid, everything, I missed the immunosuppression. So before touching this eye, she has started the immunosuppression for this young guy. And other eye, which is relatively better, started simply the pros lens. And by the pros lens, the other eye vision improved to 6/18. And he has joined his service again and again and waiting for the surface reconstruction of the other eye. That's from the failure I have learned these things also, what I missed these things. I'm just quick short the running as short of time. So this case already I have presented a study. This patient has an alternate metal injury. This is a severe chemical injury is there. So the same, just simply. So simply there's a molten metal injury was there, and there is a which devastated as a scleral melting. So what we do the surface reconstruction here, we harvesting these things, and from where the sclera melt was there, we are taking the scleral half thickness of the sclera, little increase sound, little increase. So we place it over there, secure it with fibrin glue. Additional switches has been given. BCL has been placed. Security fibrin glue. Yeah. So I am putting the alloy slits and complete the procedure. So these are the immediate post-op. These are the 6-month post-op which maintain the 6/6 clear-eyed white eye. So once everything has been failed, now you have to understand this thing. It's a time for the patient needs to send your colleague, super special cornea specialist who is doing the K-Pro. So why I'm presenting this thing, all of 4 cases having the significant drop of BCVA following the chemical injury with profound scarring with the LSCD is there. So classical case of unilateral LSCD with sound other eye, which is the source of your autoslides. So these are even studies are there. So without much more time, I'm just going to my technical messages. Management should be in the molecular and the cellular level. Need for stage reconstruction should be discussed. Tenon advancement with AMT is a hallmark surgery for the limbal ischemic chemical injury. SPG, novel approach to address the post-chemical injury, acute scleral injury. SLATE is acute surgical management can be tried. Understanding of the K-Pro, which, where and when, an appropriate referral should be there. And dedicated team approach to patient care in this challenging scenario is very much rewarding. Thank you very much. Thanks for patience sharing. I really thankful to my mentors of Chennai, Dr. Geeta for giving the hands-on surface training. Thank you very much, ma'am. And thanks to CSI for giving me the opportunity for wonderful session.
Thank you, John. That is really excellent. Douse the fire. For at least you salvaged the ocular surface. Excellent. We'll quickly go to the next presentation first, so that we make sure that everybody gets a chance to present, and then we'll come back for questions. So if the speakers can stay to time, then we can take questions from our PG, our residents, our tomorrow's future. Tomorrow's future, our future. So the next talk is by Dr. AIOCMTC1 talking about superficial foreign bodies. I think the students should not miss this one. If I go by what she showed yesterday, it's going to be amazing.
Thank you, ma'am. Thank you for that. Good morning, everyone. I'm glad there are a lot of residents.
Timer on,
That's
karenge,
my
please.
target audience for today. So my talk is on how not to miss superficial foreign bodies. So it's one of the most common cases we encounter in ophthalmic emergencies in the casualty, and I'm sure the first and second year residents go, that's the first thing. And when you remove your first foreign body, I know how exciting that is, especially if it's a corneal foreign body, 26G se nikala. So when most of them are easily spotted, but few are easy to miss, either because it was a busy OPD or it was a very busy mind in a not so busy OPD. All that we need to do is look for it with our eyes and our mind, because the eye can see only what the mind knows. So this first case, 40-year-old male presented with injury with a sugarcane leaf 3 days back, pricking pain, eye pain, and was on antibiotic drops elsewhere. He was told that there is some infection on the cornea, it will resolve, and was diagnosed as corneal abrasion and infiltrate. Yes, it does look like infiltrate. We know the description, some whitish thing on the cornea, but here I would like to emphasize on the importance of indirect illumination of your slit lamp technique. I say you do one gross, broad illumination, you are definitely going to miss this. So in the second picture, when you do an indirect illumination, you are seeing a shadow of something in there. And after you stain, you can see that the half thing that's protruding outside is taken up the stain, or it's highlighted, whether the other is not. So these are basically the thorns, the sugarcane leaf ke thorns sitting in a row. So why was this missed? Because of misinterpretation. You look at the foreign body, but you think it is something else. Now, because of indirect illumination, you are also able to see that there are two thorns sitting exactly parallel to each other. Now, why it is important is, if you miss that and you remove the thorns, once you remove one, you're going to cause some amount of stromal disturbance. After that, the second one will not be visible. So before you attempt, you need to see how many there are exactly. Removing it is very simple. It usually goes in a diagonal or way. So just the direction in which it has gone in, you just have to tease it out in the same direction. Sometimes using a forceps, a fine forceps, is also a good idea, that cause much lesser stromal disturbance than a needle. A finer forceps is preferable. Now the second case, a 30-year-old male, again injury with sugarcane leaf. So when this was brought to me by a junior consultant saying, ma'am, kuch nahi hai, there's a small infiltrate and a little subconjunctival hemorrhage. I said, okay, theek hai. It looks, there's a small infiltrate, there is a subconjunctival hemorrhage, but as a routine, any cornea case, anything on the cornea, even if you're sure there is nothing, please take a moment and stain the cornea, stain the eye. And to my surprise, there was a large stain positive conjunctival epithelial defect. Like, why should there be a conjunctival defect? And then I had a closer look. So this is a direct illumination. You're directly focusing on that, nothing is seen. But when you do an indirect illumination, you're able to see some linear black thing in the subconjunctival space. It's more obvious here. So there was this foreign body sitting in the subconjunctival space. Now why did we miss this? Because of misdiagnosis, attributing the symptoms to some other sign that's either a coincidental or an associated sign. Acha, chota infiltrate hai, uski wajah se usko pain hai, so there's no foreign body. Very easy to remove, because the patient had presented earlier, the epithelial defect, it had not healed. So you just push it, or you can push with one forceps, pull out with the other one. Now the third case was diagnosed as epithelial defect, a non-healing epithelial defect, and the patient came ke symptoms kam nahi ho rahe, had already consulted an ophthalmologist. But I'm pretty sure that that ophthalmologist did not stain the cornea, because when you stain, you're seeing those linear abrasions. The cornea is saying, yelling, please evert the eyelid, there is something there that is continuously scratching on me. So you evert the eyelid. Now this again, if you have patients who are coming from a rural area, you are definitely going to see a lot of these cases of, okay, so now when I everted the eyelid, again, nothing was very obvious. Then there was a small mucus plug sitting there. When I stained and again I everted the eyelid, that mucus plug is still sitting there. Usually if it is a mucus plug, once you evert again, that moves. Here it is still sitting there. So when you see a mucus plug sitting there which is not moving, at least take a bud and remove that plug. Usually when there is a protruding foreign body, that's a natural way of mechanism of the mucus will cover it up so that the pricking sensations will be much less. So only when I remove that and carefully I see there is a caterpillar hair. So these cases are very common, and you see multiple of them, and they get buried deep into the tarsal plate. Sometimes you have to call them second or third day and you see more of them. There have been cases where the caterpillar hair has been found into the cornea, into the anterior chamber, even into the retina, in the posterior segment. Now removing this, if you directly try to remove by forceps, sometimes it gets buried even deeper. So first use a 26G, tease it out a little, and then take the forceps and pull it out. So why was this missed? Because of inadequate examination. Either you did not stain or did not evert the eyelids. Now it is wise to learn from our experience, but it is wiser to learn from the experience of others. So when I did a literature search while I was preparing for this, you see some interesting case reports. So there is something called teddy bear granuloma, where the teddy bear hair in the kids that got accumulated and formed in granuloma, which resulted in a corneal infiltrate and corneal melting like this. This was very surprising. I mean, even I used to put bindi to my daughter. After seeing this, I've stopped it because bindi got lodged into the fornix in a kid, and that has resulted in this corneal lesion. This is very common, an insect wing. So you don't want to miss this, and a patient comes to you with an infiltrate and then you evert and then you find that there was a tiny wing. Now this is something we definitely don't want to do, is miss a metallic foreign body under the eyelid and get it on an X-ray. You see a metallic foreign body on an X-ray, which was just, all that you have to do is just evert the eyelid. Now refractile foreign bodies or glass foreign bodies are very, very easy to miss. Like in this case. So here I would like to describe a shadow sign. So if there is anything on the cornea, an epithelial defect or a dendrite or a foreign body, it will, when you throw a light on it, it will cast a shadow on the iris. So that shadow, when you move your light, that shadow also moves. So you know that, okay, there is something, you defocus and look at the cornea, what have you missed? Always look for the meibomian gland openings. When you see there is some staining on the cornea, you see the patient is complaining consistently of foreign body, look at the glands. I as a postgraduate never, I mean this was new to me as well when I did a literature search. So in the meibomian glands opening or in a punctum, you will see a cilia or a foreign body that is sitting there, and it is constantly irritating the surface.
Asmita, can you
Yes.
conclude?
So summarizing, direct broad illumination, after which do an indirect or a retro illumination, always stain, look for the shadow sign, and lastly, redness never lies. So when there is a localized redness in an area, so search in that area, you will find something. Thank you for your kind attention.
Thank you, Asmita. It's a wonderfully covered topic. The next speaker we have is Dr. Pranati Sahai. She's going to show you about corneal gluing, a video-based presentation. And while she's setting up, if I have a quick question from any of the audience. What is the most bizarre foreign body anybody has removed over here as the residents or faculty? What is the most bizarre foreign body? Yeah, very tough, yeah. Right, right. And that, yeah, and that,
You were thinking about the value retardis, also see the upper.
yeah, and that is not one round. You need to do 2-3 rounds of removal for those foreign bodies. All right, Dr. Pranati, all yours.
Good afternoon, everyone. I'm Dr. Pranita Sai, and I'll be discussing the topic of corneal gluing because this is one topic or one procedure that almost everybody, anyone and everyone can do in their OTs and OPDs for emergency patients. So the use of adhesives for
Timer,
for
please.
the cornea purpose was first described by Webster et al. In 1968, although it had been in use for other subspecialties prior to this. Now the tissue adhesives can be either of two types, synthetic and biologic, and we use both of them in ophthalmic practice. We use the fibrin glue as well as the cyanoacrylate. The cyanoacrylate glue has different side chains, that is butyl, heptyl and octyl, which gives its different adhesive properties. However, N-butyl cyanoacrylate is the one which we most commonly use, and of those of you who may have used it, you know it appears to be blue in color. That blue color is added to it so as to increase the visualization. It is not by its own properties that it is blue, but it has been an added color for its better visualization. It polymerizes as soon as it comes in contact with water. The fibrin glue, as you all know, it is obtained from bovine sources. It is US FDA approved for cardiothoracic surgeries. However, the ophthalmic use is off-label. The mechanism of action is similar to that of the blood clotting cascade. This is how the fibrin glue looks like. It comes in a pack with set of injections and 4-5 sets of vial with 2 blue, 2 black, 1 white. The preparation has been described in the box. There is an instruction set how to prepare it, and based on whether you want the fast component or the slow component, you prepare the glue with its different components on this tissue plate and finally load on to this injector system. So tissue adhesives can be used for small corneal perforations, amniotic membrane graft, limbal epithelial transplants, SALC, that is superficial anterior lamellar keratoplasties, and severe corneal thinning and desmetosseals. While the cyanoacrylate glue gives good tensile strength and is cost effective, however, it also induces a lot of inflammation and neovascularization. While on the other hand, fibrin glue induces less inflammation, dissolves with time, but it has less tensile strength. The procedure is usually done under with sterile precautions in OT. So this is a video wherein we'll show you tissue adhesive application in a case of a desmetosseal. This is the blue cyanoacrylate glue, and it is being loaded onto a tuberculin syringe with a 26 gauge needle. And this has to be done under aseptic precaution. This is the needle is then changed after loading. The patient is taken in the OT under the microscope. Under topical anesthesia, there is a speculum applied. Gentle drying of the surface was done with Merosil. And here we see that the Merosil back tip is being used to gently take a drop of the cyanoacrylate glue, which is now applied to the dried surface. Okay. Now you wait for another 30-40 seconds for it to dry. Sometimes you can try to spread it with the Merosil, but don't do it with a cotton bud, because the fibers get entangled into it and they will not dislodge. Okay, so we wait for it to dry, then irrigate the ocular surface with BSS. That will enhance the polymerization process, and after this wash, you can apply a bandage contact lens, and the procedure is done. So you can have either a direct application using a cannula or a needle, or with a plastic disc with the glue, that is also known as the patch technique. You can use this when you have a larger one and you want a uniform application on the surface. So this is another video where we'll show you the different techniques of glue application. So this is the direct application technique. This has been done, this video prepared in the wet lab. So a 30 gauge needle, a small drop of glue is being prepared at the top of the needle. You don't want, a big blob to fall when you're directly applying it. So you form the drop before applying it on the site of perforation. Okay, so this is your direct application technique. Then next is your patch technique. So in patch technique, what you do is use a 2 mm small trephine. You trephine a patch of the drape that you normally routinely use, which can be a cotton cloth or a drape patch. And this now is taken up at the back of the Merosil wick with the help of an ointment. An ointment is applied at the back of the Merosil backside plastic. And on this drape will be stuck on, this drape small patch. And on this you can apply the small drop of glue, and then apply it at the site of perforation. So this will ensure that you have a uniform application, no mound formation, and the patch will also stay there. So some larger perforations will also help in, say, perforation is around 2.5 millimeter, wherein this patch technique will be more beneficial than a direct application technique. Now, the post-operative treatment is also important. Antibiotics, cycloplegic, steroids, anti-glaucoma, and a BCL replacement at 4 weeks is important. Steroids, if it's a non-infective case, it is must, because inflammation is something which is bound to happen in patients post-cyanoacrylate glue application. And since you know that glue is going to stay there for at least 2-3 months, change the BCL if possible every 4 to 6 weeks to avoid infections. So the cyanoacrylate not only covers the area of the defect, but also arrests the stromal melting. It acts as a barrier and has bacteriostatic properties. So it heals up the, there have been comparative studies wherein fibrin glue has been compared to cyanoacrylate in perforations. However, the success rate appears to be same, almost same, 86 and 79 at 3 months. The adhesive plug formation is obviously faster. The cost is cheaper for cyanoacrylate. The tectonic support is better with cyanoacrylate worthy results. So this is a patient who had a post-traumatic corneal perforation. You see, there is a wire which is sticking direct inside the cornea going in the anterior chamber. Such small circular perforations cannot be managed with suturing. It is best to glue them up so as to maintain the corneal anatomy at the best. So this is the 2-month post-BCL glue for a perforated ulcer. It heals up with a scar and vascularization, but you have a well-formed anterior chamber, and later on you can take these patients for optical rehabilitation or visual rehabilitation. Sometimes you can have aggressive vascularization, hence steroid use is essential in these patients when you are managing them. So tissue adhesives work well in small perforations less than 3 millimeter. There are various indications that we have already discussed. Cyanoacrylate provides good tectonic support and is cheap, but fibrin always induces less inflammation, but is also expensive. Thank you.
Thank you for an excellent talk. I think you've covered the topic very well in the time that you were given. Just one point I had to add is that rather than using the back of the Merocell sponge, which I used to do earlier as a fellow, what I do now is to use a 26 gauge needle with the bevel up. So use the bottom side of that and just take some glue, and that really helps very much for all these cases, desmetocel, and because there's a differential thinning in these cases, so you can get a much thinner monolayer. Sometimes with the back of the Merocell sponge, especially when you're starting off, you might be able to get a thin layer, but when you're starting off, you just get a thick blob over there. So I keep telling the fellows that why you put buckets of glue on this eye, and then you painting it with 26 gauge actually works better. So those of you who are starting off using the glue technique, cyanoacrylate glue, so instead of using the back of some thicker instrument, use the fine needle. So just put it in the glue and just paint it very gently. So you'll get a very thin, you just need a monolayer of glue. The idea is not to have the dense white appearance. You just want a very thin crystallization kind of appearance. That's enough to hold it. So any questions from the audience, students? No questions. If any of them come as your examiners, you've had it. You're not asked. You might as well just take your revenge now. They won't hold it against you. All right. We thank you once again. We move on to our moderator, who will now go back to moderating the session.
Okay, thank you, ma'am.
The last topic is very interesting. Don't leave.
So we'll move on to the next presentation by Dr. Anil Radha Krishnan, and he'll be presenting on cornea and systemic diseases.
Dr. Anil Radhakrishnan has come all the way from Kerala, Kochi. And AIO's main meeting is there this year, so you guys must attend that as well, and he'll take care of you.
Yeah, thank you. Thank you, CSI and Somshila, for the opportunity. I think I've been asked to cover the cornea and inflammatory diseases. I don't wish to be comprehensive. I thought I'll focus mainly on peripheral ulcerative keratitis, which is a very pertinent topic. So what is peripheral ulcerative keratitis? It is basically a destruction of the cornea associated with limbal inflammation. And as it is taught to you, you can see this overhanging edge. So you can actually go inside, like with the 26 gauge needle, you can go underneath that overhanging edge and see that some part of the cornea is distracted. You know, if you take an OCT, you can see the overhanging edge. And whenever there's an active infiltrate, it will appear more hyperreflective. That white color would be there. So what's the importance of PUK? PUK can be the macro-ulcerative PUK. That is what I mean about PUK. It can be micro-ulcerative, which is staphylococcal marginal keratitis and stuff like that, which is bothersome but quite innocuous. But macro-ulcerative PUK and necrotizing scleritis is a much more severe form of vasculitis. If it is not treated properly, more than 50% of the people will die within 5 years. It's your responsibility to pick up the case and actually treat the disease process. So it's, as an ophthalmologist, it's our responsibility to pick up that case. And if it is treated, most of the people, more than 90% of them, can easily be saved. So whenever you encounter a PUK, you have to do a systemic evaluation for connective tissue disorders. At least the basic collagen workup you should do. The inflammatory markers, ESR, CRP, ANA, and RA factor. I think the dermatologists would add much more to it, but at least this much we should do. And it makes sense to look at the other parts of the eye as well, even the other eye. If you have evidence of scleritis, like if there is a choroidal show, or if there is very severe dry eye in either of the eye, and if you see these mucus clumps, debris, filaments and all that, it is very likely that you're leading with systemic disease. And sometimes the eye would be white and then you can still have this choroidal show, as you see here. Sometimes you don't see scleritis, but you can see evidence of sclerosing keratitis as seen as whitish discoloration of the peripheral cornea. These are all telltale evidences that there is some other inflammatory process happening in the body, in the eye. So the treatment of the disease is basically the treatment of the underlying condition. Our aim, whatever ophthalmic treatment we give, is only supportive. So the treatment has to be tailored, like systemic steroids has to be given. If it is a very severe form of disease, you have to pulse the patient. That is, you have to give IV methylprednisolone and get the disease process under very good control. And sometimes you have to use IV cyclophosphamide also. As an ophthalmologist, we have to use, basically our treatment is supportive, as I said before. We have to use liberal preservative-free lubricants. And it's a good idea to put in a plug so that the tear film is much more in volume. Once the disease process is under control, we have to suppress the ulceration and provide sectonic support by giving peritomy and cyanocolate glue. So it's very important that you distinguish between Murren's and PUK. In Murren's, it is a localized autoimmunity. It's usually the cornea-associated antigen against with the antibodies working against. So as I said before, the difference between Murren's and PUK is that Murren's, the treatment is topical steroids essentially, while in PUK it is systemic immunosuppression. So depending on the disease, like if it's vaginous and very severe form of vasculitis, you have to admit the patient, pulse the patient. Quite often you have to give methylprednisolone also. And most of the conditions like rheumatoid arthritis, somewhat moderately severe, you can just give systemic steroids 1 milligram per kilogram and it should be done. In Murren's, it is topical steroids. Then you switch up the treatment to peritomy plus glue and then systemic steroids. And then if it is not working, then you have to go for systemic immunosuppression. So both Murren's and PUK can actually rip across the cornea like this in certain situations. I think I'm not going into the details now, but I think in very severe form of disease, you can use the biological agents like infliximab, rituximab, and adalimumab. So I'll just take 2 examples. This is a patient who was an auto driver who came with a peripheral ulceration of the cornea, showed about 80% thinning. Basic collagen workup was almost normal except a slight elevation of the CRP. So we gave topical steroids thinking that it's Murren's in young. And we saw that there is necrotic tissue in the center part of the cornea when we added the systemic steroids. There was some response to systemic steroids in the initial period, but later there was more necrosis happening in the center. We had a differential of secondary infection versus worsening of the disease, took the corneal scraping, microbiology, and in the same sitting did the peritomy and tissue adhesive plus bandage contact lens, after which the disease settled down. But once the glue got dislodged, the disease came back again. And we restarted steroids with little effect, but then we had to put him on a repeat conjunctival resection plus DAPACL. Then this time we started steroids, the methotrexate also, and the patient has been on a good follow-up. So this patient has completed 3-year follow-up now on a very minimal dose of methotrexate, just 7.5 milligram once a week, and is doing pretty well. Case number 2, a more severe form of disease, a 45-year-old lady with vaginous granulomatosis who had bilateral CSOM and had chest lesions as well. So at presentation, she had this PUK along with scleritis, and in fact, she had an optic nerve head granulomatous process, and with which she lost vision in one eye. The other eye had again severe scleritis and PUK. So because she lost one eye, we had to admit the patient, and this patient, despite the best treatment by the dermatologist in the initial period, she was on maintenance steroids of 20 milligram a day, Azoran more than 100 milligram, and mycophenolate more than 3 grams a day. Still the patient was not responding to treatment. The disease process was happening. So we had to use a biological agent. We used rituximab, and after 3 doses, the eye just quietened down. So it's very important to pick up the disease. When the amount of antibodies and cytokines are very high in the circulation, it's much more difficult to treat the disease. You have to use much higher dose of steroids, IVMP and all that, and quite often you have to use multiple doses of rituximab. But if you pick it up early, once the disease is early in the process, then you can treat it much more easily. So in the interest of time, I'm not going to the patch graft. Once the disease process is good and under good control, we can go for the patch graft. And if you do a patch graft, it is not necessary you have to be limited by the roundness of the trephine that you have. You can do a customized patch graft. In this, I have taken a quadrangular shaped patch graft. I just cut a bit of our drape. It is cut in that particular shape, and that was used. And 3 or 4 years later, patient came for the cataract surgery, and the graft was looking nice. So I would like to conclude saying that it's very important to identify PUK, not only for the eye, but for the life of the patient. And prompt immunosuppression is a must, and you should team up with a dermatologist to do that. And surgical repair, as far as possible, should be done after control of inflammation as much as possible. Thank you so much.
Thank you, sir. That was a wonderful talk, and on that vast topic that you covered so nicely. Sir, I have one question. Sometimes we have very severe cases of PUK where 360-degree melting has happened, and you have a central part cornea which is intact and sitting there. So how do you manage these patients?
Okay, so we obviously will take the rheumatologist's opinion and tease the disease process, and usually the destructive process of the cornea stops there. Then depending on the astigmatism you can do, like if there is no much of astigmatism, you can, just for the tectonic support, you can do a multi-layered amniotic membrane. That would be my preferred strategy. But if it is so severely ectatic, you have to go for multiple crescentic peripheral lamellar grafts. So sometimes you have to use 3 or even 4 grafts, and then only you can tackle it.
Thank you, sir. Anybody wants to ask any questions? As such, we are running short of time. But any questions? Okay. So.
Yeah, it is preferable to do because these conjunctival vessels carry the antibodies, and when you have an antigen-antibody interaction happening in the peripheral cornea, which leads to complement activation and collagenase activation and the disease process, so it's better to block it. One, mechanical blockade that you're doing with the cyanoacrylate glue. Second thing, you are blocking the antibodies from reaching the circulation by doing a peritomy. It's advisable to snip away, take away some amount of tissue also. Yeah, I think, see, if it is so much of a perforation that the tectonic integrity of the patient is compromised and it's about to perforate, then only you have to think of a multi-layered amniotic membrane. We would, in the first step, would prefer to do a glue. And usually, quite often, most cases, it will get settled down with the glue itself.
So would you suggest Tenon patch in patients who have PUK with autoimmune diseases, because it's an inflammation that is going to involve the eye and going to involve the entire tissue? So Tenon patch in autoimmune disorders with POK? Or
Yeah, I
will
have
go
not, I have used tenons, but not exactly in these cases, but it should also work.
Okay, sir.
Somshil, any
we'll
comments
end
on
the
that?
session because we're over time. Sorry.
Yeah.
Excellent talk, I agree. And thanks to all the speakers because we've gone over time into the next session. Though we got this late actually, so we apologize for that. And it's been just great to have all the students here. So thank you very much to my co-moderator as well.